All right. Hello, good evening, and to all the audience in India, and good morning to all the people attending from US. So I welcome all of you on behalf of IS and MSc webinar series. And this webinar series would be a 35 to 40 minute talk, followed by 15 to 20 minutes of Q&A session. I would request all of you to mute your phones and devices during the talk, and you can post your questions in the chat, or you can ask afterwards in the live Q&A session. And it is my absolute pleasure to introduce Dr. Tarang Vora, who is a pediatric and epilepsy neurosurgeon. He's currently working at Apollo Hospitals, Hyderabad, and he has an experience of 13 years in these fields and holds dual fellowship both in pediatric neurosurgery from AIIMS New Delhi and CMC Vellore. He took training from Milan, Italy for surgery for drug-resistant focal epilepsy. He has numerous publications in national and international journals. Without further ado, Dr. Vora.
Thank you. So I'll just start with it. So basically today I'll be talking about little bit of history of epilepsy surgery, the surgical techniques, a little bit about focal cortical dysplasias, and image post-processing techniques that we are utilizing over here to zone in on the epileptogenic zone before we proceed for resection. And I think most of the talk is theoretical, but in the end, I'll share one of the cases about how we go about doing this over here. Epilepsy is considered as a sacred disease, and this is a painting that we have in a museum in Madrid which was painted in 14th century. Uh, Basically, epilepsy in older times, over the last couple of centuries, has been believed to be a divine curse or somebody who is possessed by evil spirits. And trephination has been one of the treatment options for people who are possessed by evil spirits. And this is one of the paintings from Madrid, which I had seen when I had visited Spain, and it gives me good fond memories about how the process for epilepsy surgery had begun so many centuries ago. But in reality, it is starting somewhere in the late 19th century with two guys. One is Huglings Jackson, and second is Victor Horsley. For epilepsy surgery, it's always a teamwork. Nobody can do it alone because the amount of information and amount of decision making that is required to do a safe epilepsy surgery requires involvement of multiple members. So Hugling Jackson was the one who was first able to suggest that seizures or maybe part of a brain uh, is controlling a particular part of the body. So with his neurological work, people came to an understanding that each part of brain is responsible for different function, and whatever he said from a theoretical perspective was put into practical aspect by the neurosurgeon Victor Horsley from UK. So both of them are, of course, Huglings is more senior, but Victor Horsley was able to produce whatever Huglings was able to document from his neurological examination from patients who had different types of seizures or brain tumors. Uh, uh, Predominant work on epilepsy in the earlier 19th century or the early 20th century was published by Victor Horsley and then followed by uh, his juniors and whoever he taught in further line. So after that initial era of Huglings and Horsley, we have the Montreal era where we have Penfield and Jasper. So Huglings was a neurologist and Horsley was a neurosurgeon. Similarly, Penfield was the neurosurgeon, and Jasper was the epileptologist or the electrophysiologist who was able to map out different areas of the brain. And they have this very famous homunculus, which is they came up with in the earlier part of the 20th century. And this has formed the basis for predominant work in neurology as to where exactly the seizure is starting from. And it's a fantastic how they have worked together as a team to be able to reproduce the homunculus. He was called as a cerebral cartographer, basically somebody who is mapping out the brain to point out which part of brain is controlling what. Uh, After that, there was a silence of about 50 years. We were suspended by the World War, and once the World War ended, then we had John Becord and Jean Talairac in France, who did some excellent work of cartography, but not from the brain surface. They wanted to record from within the brain. What Penfield had done was that he was recording from the surface of the brain as to which area is controlling what. But Talairac and Bancord, again, Bancord was a neuropsychiatrist and Talairac was the neurosurgeon. Uh, they developed a special frame to map out which part of brain is exactly doing what, and to record the electrical activity not from the surface of the brain but from the depth of the brain. They used to put a certain kinds of electrodes which nowadays are available as stereo EEG electrodes, that instead of recording from the surface of the brain, we record right in the depth of it by implanting electrodes inside the brain. Here we have the images of the brain cut section, which is showing multiple holes in it. Basically, that is how the electrodes were inserted and the recordings were taken. This is them performing the same at Saint Anne Hospital in Paris in France, uh, where the patient is fixed to the frame and then they put in multiple electrodes to record the electrical activity from the depth of the brain and to find out which part of the brain is responsible for the abnormal electrical impulses, which in general is leading to epilepsy. This is the modern era of the same thing which was done 4 decades ago. This is how we do stereo EEG now. We have a map of the brain where we plan out different areas, and then we make tiny holes on the skull under the guidance. As you are seeing on the image on the right, the patient is under an O-arm. O-arm is an intraoperative radiological device which takes the image of, it's like a CT scan, but in an intraoperative phase. And during the surgery, we are able to merge the image of the preoperative MRI with the plan and the O-arm to see if our location is accurate of the electrodes that we have placed in the brain. So yes, brain is an electrical network and it's continuously discharging, and that is what is recorded by the epileptologist from the scalp that is above the skin. But it's not a very great recording because there is bone in between and then there is skin in between, and the impulses that we are getting from a deeper structure may be slightly more diffuse. So there are different ways to bypass that from a surgical perspective. We can open the skull and put the grid right on the surface of the brain, or we can do something like stereo EEG, where we put electrodes in the depth to make a recording of it, which is analyzed by the epileptologist to find out which area of the brain is responsible for giving an abnormal electrical impulse, which is leading to a drug refractory epilepsy. So we have this multiple zones. A seizure onset zone is one where this abnormal epileptic activity is starting. It generally corresponds to the epileptogenic zone. And there is some zones that are outside this zone. That is an irritative zone and a symptomatic zone. Symptomatic zone means when the electrical activity spreads to a certain part of the brain, which is responsible for a certain activity, like part of the brain which is responsible for the tongue, part of the brain which is responsible for the hand. When the seizure activity spreads there, uh, we call it the symptomatic zone, and that is what the patient experiences, as in the jerking of the hand or the leg, depending on where the electrical impulse is spreading during the seizure. That kind of a march of the electrical activity from one side to the second side is called a Jacksonian march, and that is what was Hugling's Jackson. That was the first person to describe this in late 19th century, along with Horsley, and that's how the epilepsy workup has begun over the last couple of last 100 or 120 years. So, as a surgeon, how do we know what is the epileptogenic zone? The intent of providing surgery for epilepsy is that if we are able to resect the seizure onset zone or the epileptogenic zone, we are giving freedom or cure from seizures to the patient. And that is the intention of epilepsy surgery. So, when we are looking at modalities that are available for us to find out which is the epileptogenic zone, we have multiple modalities ranging from PET to EEG to ECOG. ECOG is surface based electrical readings to stereo EEGs, uh, to MEG to EEG. So, basically, when we're looking at EEG, EEG has got extremely good temporal resolution, okay, but extremely poor spatial resolution. So for instance, if an EEG, depending on which electrode, is showing an abnormal spike in electrical activity, that electrical activity can be in anywhere around 10 centimeter radius from the surface of the brain. So if you have an electrode somewhere, maybe F3, that is on the frontal region of the brain, which is showing an abnormal electrical spike during the seizure, it basically implies that the seizure area where it is starting can be in a range of approximately 10 centimeters uh, in a diameter around that, and that is a huge area, and we can't do surgery and resect 10 centimeter of a brain. So we need much more detailed information to find out where exactly the seizure is starting, and all of these modalities play their own role in us being able to zone in over there. So when we are looking at surgical techniques to address epileptogenic zone, there is currently and there has always been only one surgical technique which is curative for drug refractory epilepsy, and that is resection. If we are able to find out where it is starting and resect the part, the patient is going to be seizure free. The other modalities, when we are not able to find out where the seizure is starting in a drug refractory patient, is disconnection, where we do calostomy or hemispherotomy. We also have the option of lesioning, that is laser interstitial thermal therapy or radiosurgery or stereo EEG guided radiofrequency ablation. And the last one is neuromodulation, vagal nerve stimulation or deep brain stimulation or responsive neurostimulation. For me, neuromodulation is more like homeopathy. It's nobody knows how it's working, but it does work sometimes. And there is no scientific way of us being able to prove how exactly neuromodulation is helping patients with epilepsy. It does bring down the seizure frequency, but it is not cure. None of the last three are cure. The only cure is resection. So if there is an epilepsy surgery program who is not offering resection predominantly, then that is not a good epilepsy surgery program. Uh, Other modalities is when we have ruled out that you cannot do a resection for the patient, and that is when the other modalities come into play. The point about seizure is that when we are talking from a surgeon's perspective and not from a neurologist perspective, we're looking at only two types: a focal seizure, a patient having a focal seizure, and something that is structural in nature, which is not related to some perinatal insult or infection or genetic or a metabolic thing. So when I get a patient for epilepsy surgery, all of this has been ruled out by our epileptologist, uh, who are extremely good in diagnosing and finding out what type of epilepsy it is, and they are able to tell us. They have that guess thing that they are saying that it is structural, it is none of this, and but we are just not able to see it on the MRI, and that is where the image post processing tends to help. So when we're looking at epilepsy surgery in general, we have a lot of things that we treat with epilepsy surgery. The most common is hippocampal sclerosis, followed by focal cortical dysplasias, heterotopias, schizencephalies, hamartomas, hemimegalencephalies, polymicrogyria, band heterotopia, and of course, the small benign tumors like DNET and gangliomas, AVMs, angiomas, and post-stroke patients or post-MCA infarct patients or ICA infarct patients who have some gliosis in the brain, who which the surrounding cells are getting hyperexcited and causing a seizure. So the point of image post processing is to identify focal cortical dysplasias. And it's the other aspects, like something that is a tumor or an AVM or an angioma, uh, are easily identified on imaging and can be treated. But things that are not visible on the MRI, that is what we are dealing with. And when things are not visible on the MRI, but the epileptologist is sure that the seizure onset is focal in nature, the semiology of the seizure is focal in nature, and the epileptologist is sharing data that it does not look genetic or metabolic, then we are looking at the MRI, and the MRI is normal, and then our role starts with the post processing to find out where exactly is this dysplasia. So what is a focal cortical dysplasia? The definition of it has been changing over time, but it was Mr. Taylor in 2000 in 1971 from UK who gave us the definition. He was working at a neuropsychiatric institute. Of course, most of the seizure patients back then were in a psychiatric hospital, and not as neurology was still growing. And then followed by Andre Palmini. He is a neurologist from Brazil. He has given a definition of focal cortical dysplasia, and the current definition of focal cortical dysplasia is by Dr. Ingmar Blomke. He is a German pathologist who has given us different subtypes of dysplasia. So it has moved from neuropsychiatrist to neurologist, and it has now gone to pathologist, where we are resecting brain sample which looks normal to the naked eye, but patients become seizure free, and the sample we send to the pathologist, and the pathologists are able to tell us that yes, this is brain, but it is slightly dysmorphic. So what is this dysmorphic brain? And that this dysmorphic brain is focal cortical dysplasia. Focal cortical dysplasias are neuromigration disorders, basically meaning that during the process of neurogenesis, or when or neurulation, the migration of neuron happens from the ventricular end till the cortex. And in that migration process, some of the cells are left behind or could not reach their potential, or somewhere stuck in between during the neurodevelopment, and those are something we call as dysplastic tissue. On the left, we have the typical six-layered human cortex with different type of pyramidal cells. You're seeing the neurons which are triangular in shape, and the star-shaped astroglial cells which are helping them out or binding them together. But when the same neurons in the six-layer cortex are not organized in a typical fashion, are in a disorganized fashion, we call them as focal cortical dysplasias. If it is organized in a disorganized fashion, but the cells are normal on pathology, we call it as FCD1. But when we see some abnormal cells, something called as balloon cells, as is seen over here in the purple with the green dot, we call it as focal cortical dysplasia type 2. The balloon cells are basically cells which have lot of cytoplasm in it, and because it has a lot of cytoplasm in it, it has got a lot of water in it, and lot of water in it basically means that we're going to catch some good signal on MRI, very good quality MRI on the T2-weighted and the flare sequences, because the water content is more compared to an average brain. On the right, we have an image of a rat neuron, in which from the germinal surface, you can see how the neurons are starting to migrate and transferred and keep on traveling upwards. This is called neural migration that happens during the early part of the gestation, where the brain cells are migrating cranially from the periventricular zone. So not to bore you too much about the pathology, but this is the ventricular end and this is the cortex, and we have the cells that are migrating along this line. During the organization and the migration phase, uh, eventually there is proliferation of these cells, and there are these six different zones, and these six different zones are also visualized on immunohistochemistry. And when this thing that we are seeing on the left side, the HNE, if the structure, the six zones, we are not able to make out clearly, and it is disorganized, but the cells are normal, that is what we call as a dysplasia. So FCD type 1. Now they are very difficult to detect from a radiological perspective. So I have few examples where we are able to see it on radiology. FCD type 1, 1A, 1B, 1C, 2A. These are not very clearly visible. FCD type 2B is the only type which is visible on a very good quality MRI. Uh, this is an FCD in the temporal lobe, which is seen type 1. This is an FCD type 2 patient, which is showing some hyper intense or a thickened gray matter cortex. You will understand it if you it's on gross examination. The MRI looks pretty normal, and it's not like you will see a tumor or something. But if you're looking over here, I don't know if my arrow is visible on the sharing screen or not, but there is a lot of gray matter over here, and there is not equivalent amount of gray matter on the contralateral side, and this is what is FCD type 2B over here. 2A, sorry. And this is another FCD type 2A where we have this, and then we have some arterial spin labeling showing some area of hyper metabolism over there. Yes, arterial spill labeling is a good technique if we want to avoid nuclear imaging, but in our practice, we believe nuclear medicine provides, or the PET scan provides much more definitive data than the ASL and more reliable data. So FCD type 2B is visible. This is the end depth of the sulcus where we have this hyper intense signal that we are seeing on the flare image on the coronal section. And we have this on the axial section where we have this. This is visible when the quality of MRI is very good. It can be easily skipped over and may not be reported by the radiologist if the quality of MRI is not great. Again, another FCD type 2. B, the FCD type 2B has a peculiarity of having the balloon cells, which I showed in the previous slide, which has got a lot of cytoplasm around it. And because it has got a lot of cytoplasm around it, it has water content is high. And because water content is high, it is going to pick up on flare and T2-weighted images. There will be a tract that is, we call it the transmantle sign, which comes from the depth of the sulcus and goes towards the ventricle. We talk about the ventricle because the neurons migrate from the subependymal zone around the ventricles towards the cortex, and in this migration, when they are left behind and they have never reached their ability to reach the cerebral cortex, they leave behind a tract behind, and this tract is what we call as the transmantle sign, which is common in FCD type 2B. This is a very good transmantle sign, which again is seen in FCD type 2B. So over the decades, there have been a lot of classifications. Uh, Basic understanding is FCD type 1 is where we don't have abnormal cells, but the organization of the neurons is abnormal. Type 2 is where we have some dysmorphic cells like balloon cells, which are present. And type 3 is associated with other anomalies like brain tumors or vascular malformations. And then now we have two more types, something we call as MOGE, this minimally or mild cortical dysplasia, where the organization does not look abnormal, but we have some oligodendroglial hyperplasia. All these terminologies have come from the surgeon's perspective. It's like the neurologist focuses, and whatever imaging modalities we utilize, we zone in on a particular area and we feel that area is causing the seizure. We go ahead and excise that area. After excision, if the patient has become seizure free, our hypothesis has come true. Now that specimen that we have excised needs to be analyzed by the pathologist to tell us what's exactly wrong with it and why it was causing a seizure. And sometimes the specimen looks so normal, we are not able to say why it was causing a seizure, but then the pathologist may identify some subtle changes and they come up with some new terminology to suggest why this case was producing a seizure. When a pathologist reports something, the reporting is on three aspects now. One is the histological diagnosis, the second is the subtype, third is the genetic finding. Genetics and molecular diagnostics is coming in a big way in epilepsy. We are sending the specimens for analysis, even though with to look for different type of somatic mutations. Neuroimaging findings are also part of this, and it's necessary that we are able to stratify which patients benefit, which patients don't, and for that, good reporting is mandatory. For example, an illustrative case would be an MRI of a diagnosis would be an MRI positive bottom of sulcus focal cortical dysplasia type 2B with a somatic mutation, like for instance an mTOR mutation. What is a good MRI? A good MRI is depends on multiple factors. We have to tell the technician what we want. The image on top, A is the MRI, and B and C are the MRI of the same patient done with different Tesla or with different protocols. So in image 1, we are not able to see the dysplasia, but in image B, we are able to see a little bit of the dysplasia, and in image C, we're seeing it so nicely. The dysplasia is the tract that is running from the ventricle towards the end of the depth of the sulcus. Imaging plays a very critical role in identifying it, much more critical role than EEG or stereo EEG or electrocorticography. We have specific guidelines on how we want the MRI to be done, and the process is called as a harness protocol. This protocol basically means that we want a T1 weighted image, which is very thin, multiple slices. The voxel size has to be 1 into 1 into 1. A flare sequence, 1 into 1 into 1, and a T2 weighted sequence. So these are 3D T1, 3D flare, and a 2D coronal T2 weighted image, but the orientation of that has to be parallel or perpendicular to the hippocampus, because we are trying to, most common type of epilepsy is going to be the hippocampal sclerosis, which is arising from the temporal lobe. When we reformat the images, we want to reformat them in the same 1 millimeter isotropic reformatting. If we reformat the 3D images in a 3 millimeter gap slice, we may miss the dysplasia. So it's necessary that the slices are very, very thin or no gaps at all. It has to be a high quality 3D MRI. The 3D sequences, we require only two 3D sequences, 3D flare and 3D T1, and one 2D sequence, that is a 2D coronal T2 weighted sequence. Only 3 sequences are sufficient. We don't require any contrast or SWI or GRE sequences for us. These 3 sequences are provided. It is sufficient for the surgeon to take it forward for any post-processing. So till now, we have just discussed the basic thing and of the epilepsy. And currently, all the centers have 3 Tesla MRI. People have started acquiring 7 Tesla MRI so that some occult regions which may not be visible usually can now start to become more visible on 7 Tesla MRI images. Diffusion weighted images, fMRI, EEG, fMRI, PET, all of this are integrated together to call something as multimodal imaging. So this multimodal imaging is something that helps the surgeon to decide which part of the brain the surgeon wants to resect to give the patient good seizure freedom. So starting with the true topic of discussion is the image post-processing. Image post-processing happens when you provide a technician or an engineer or a surgeon who is trained with post-processing with a good quality MRI T1, 3D T1, 3D flare sequences. Once you provide the 3D T1 and 3D flare sequences to the surgeon, he will go through a certain, or the engineer, he will go through a certain sequences uh, of processing the image, and that is what we call as image post-processing. So starting with the first post-processing method, we have texture analysis. Uh, what texture analysis means, that it's basically, these are statistical or mathematical based analysis which is done by the computer. It is not done by the human eye. So what computer can detect, the human eye cannot. So the the computer basically breaks down the signal from a T1 weighted MRI into multiple voxels. Like we have pixels, that is a 2-dimensional thing. Voxel is a 3-dimensional thing, as you can see the cube over here. The image on the left side is showing cubes. This brain image is broken into millions of voxels. Each voxel is going to have a different color depending on where the voxel is. If the voxel is in the gray matter, it will have a gray color. If the voxel is in the white matter, it will have a white color. If the voxel is at the junction of gray and white matter, then it will be uh, uh, a blurred voxel. So whenever we have a focal cortical dysplasia or an abnormal cells producing some abnormal seizure-like activity, that is a dysplastic tissue in the brain, we may not be able to see it on the MRI with the naked eye, but the voxel-wise distribution or the cut down by the computer helps the computer to identify any change from abnormal. For the computer to be able to do it, computer needs a set of normal data. So there is a set of around 100 patients of normal gray white matter junction and the voxel frequency and density, and that is compared with this. So in texture analysis, basically we are comparing the intensity of the signal. So first on the image is gray matter thickness map. So it will look at how thick the gray matter is, whether it is too thick compared to average or it is normal thickness. Second is the gradient map. So gradient map is basically looking at the junction of gray and white matter, where if there is a dysplasia, there will be blurring, as in the transition from gray matter to white matter will be blurred. It will be like a slow transition. Whereas in a normal brain, the transition between the gray matter to white matter is like very sharp. The gray matter ends and the white matter starts. So the graph or the histogram that is formed is more of a peaked one, whereas this one, which is more of a shallow one. And the last one is a relative intensity map. All this processing is done by the computer. Based on these three things, that is gray matter thickness, relative intensity, and the gradient, when we multiply the gray matter thickness, so a dysplastic tissue will have more thickness. So that will pick up the dysplastic tissue will have more intensity, that will pick up, but the gradient will be less. And when we doing that calculation, it gives us something called as a ratio map. And that ratio map is what gives us where the dysplastic tissue is. And now in this MRI on the left, you are seeing this MRI on the left where there is a dysplasia, and that is highlighted extremely well by the post-processing image. And that post-processing image, when we are using with the navigation system that is available in our operation theaters, we are able to demarcate which area of the brain we want to resect. When we are resecting this area of the brain, that it does not look abnormal to us, it gives us the feel of the normal brain itself. Of course, doing more and more surgeries, we are able to get a feel of maybe this tissue is much tougher compared to the normal brain, but it takes some time for the hands to get that feedback that after multiple surgeries, we understand that yes, this tissue is slightly different. But it is not like a tumor. The consistency is somewhat like normal brain without highlighting or without demarcating what we are planning to resect. It's very difficult for us to give seizure freedom to the patients. Second, and the most, this is something that I'm really proud of. This work has come out of India. Like the texture-based analysis is something that came out of Canada at Montreal, and but this is something that the team at Amrita in Cochin has done. Is asymmetry index in an anatomically symmetrized FDG PET for improved epileptogenic focus, and probably. Since the listeners are more of a nuclear medicine background, I think this is a paper that must interest them, and we are utilizing this for our epilepsy surgery work over here. And this is a fantastic team in Cochin who's done really good work. So what basically is PASCOM? So PASCOM is basically anatomical symmetrization with MRI co-registration. So when we are seeing on this image on the bottom, we have the PET CT that has been done for the patient. Of course, we are seeing that the right side temporal lobe is hypometabolic for the patient, and the right hemisphere overall is showing some hypometabolism. We register the same on the MRI of the patient, and we compare the hypometabolism pattern of one hemisphere with the contralateral hemisphere to give us a very good pattern whether there is any particular area of hypometabolism. So the instead of having a database of normal patients, like for example, the previous texture analysis was based on an average of 100 patients who are normal and do not have seizures. This is based on the contralateral hemisphere. In case of a focal epilepsy. If it's a diffuse one, then of course PASCOM is going to misguide you. But if you're looking for a focal epilepsy and you know where it is starting from, if the hypometabolism is correlating to that area, it gives us a better judgment as surgeon as to where we are supposed to look at. Of course, the hypometabolism will always have spread along the area where the seizure is passing, but this is an overall view of what they exactly are doing at Amrita, and we are also doing it over here. The T1 weighted MRI is acquired and it is fused and overlaid with the PET image, and then they flip over the PET image. So when they flip over the image, the left becomes the right and the right becomes the left, and then the left and right are overlaid, the flipped images are overlaid on each other, and when they are flipped images are overlaid on each other, the same areas subtract each other, whereas the area where there is a asymmetry between the two hemispheres will start to light up. So the subtracted image will show the metabolism pattern only, which is hypometabolism, or hypermetabolism pattern only, which is abnormal compared to the contralateral hemisphere. The last type of analysis that we are practicing over here is called as morphometric analysis. It improves the detection of FCD. So as I said, voxels are basically, we are dividing it into multiple substrates and then we are analyzing it. Compared to texture analysis, voxel analysis is looking at volume. Texture is looking at the intensity of the gray signal, intensity of the white signal in each voxel, whereas VBM is looking at the volume, the structure that is inside. To differentiate between texture analysis and morphometric analysis, this thing is very simple. Texture is looking at intensity. It's a busy slide, but the morphometric analysis is looking at only volume. Volume, size, shape of anatomical structures. So it's looking at the anatomy predominantly, and whereas texture analysis is looking at the intensity predominantly. Uh, Basic goal of both the techniques is to characterize the tissue properties, to find out if we are able to spot something abnormal for, and giving us an ability to go there and resect that area. We are also doing ICV, normalized hippocampal volumetry. This is also done by a lot of radiologists, uh, uh, but it has to be done. So ICV normalized is that intracranial volume normalized. So intracranial volume for different people is going to be different. So depending on what is your intracranial volume, you have to adjust the values of the hippocampal volumes to find out if there is any atrophy in the hippocampus or not. So last part of my talk, I'll show you an illustrative case of what we are doing over here. So this is a 2-year-old girl, first born, no significant perinatal events, first seizure noted at 1 month of life. There was a gross delay in motor milestones. She's 2 years, uh, can only sit tripod, and sometimes can roll over, cannot sit without support yet. She always requires support. Multiple seizures, hundreds of seizures happening every day. They have gone through the routine process of being it labeled at West syndrome, infantile spasms, and multiple treatments given. They came to our epileptologist. Our epileptologist is so smart, so sharp. She was able to point out this is structural in nature. This is not infantile spasms or a routine one. Child had gone through, has already taken 4 or 5 anti-epileptics. Of course, the MRI was absolutely normal, but the EEG was showing right parietal region sharp waves, more predominantly in the right parieto-occipital region. So the EEG was somewhat focal, uh, and more parietal and occipital, much more region, not correlating with a typical EEG of a child who is having maybe a genetic etiology or a infantile spasm kinds of an history. MRI was absolutely normal, was reported normal. We had repeated it. This is the MRI of the patient. You can take a look at how the gray and white matter is looking. It takes approximately, for each case evaluation, if you want to look at the MRI, it takes 15-20 minutes minimum to go scroll through the MRI to get an idea of how it is looking. The left side was the T1 weighted, the right side was the flare imaging. There is no significant dysplasia that was noted on the flare. as well as T1 weighted images. We have a 3 Tesla MRI over here, and it's a very well regulated MRI protocol, a very sharp protocol that we are following over here, especially for the epilepsy cases. But this was a case where we were not able to see anything. So what we did is we 3 Tesla MRI, we asked for a 18 FDG PET. Dr. Jyotsna's team had done this for us, and we basically process the data from, so we have I have lot of softwares on my computer. I think apart from a neurosurgeon, I am sort of an engineer also. Spending so much of time on FreeSurfer, CAT, MATLAB, so many things that we are doing. We don't have an engineer here at Apollo with us. Maybe bigger institutions have the liberty of having an engineer with you to do all this analysis. Currently, I'm doing it on my own. But in future, if we do have somebody to take care of this part of care, it would be really helpful for us too. But as of now, this part of care is completely my responsibility. We use the MATLAB software. We upload the images on SPM12. And then with a CAT tool, 12 box and a free server analysis, we do the voxel-based morphometric analysis, texture analysis, PASCOM. Syscom is something that I am not doing. Even though we are doing SPECT imaging also, Syscom is outsourced to the person she is doing it on her own and helping us out with the cases. And I am doing ICV, normalized hippocampal volumetry. So this is the voxel-based morphometry of the patient, and this is the highlighted area, which is showing that on the morphometric analysis, the shape, size, and volume of gray matter that we have in this region is abnormal compared to the average 100 patients of a similar age who have a gray white matter. So when you're with the morphometric analysis, the highlighting is there, but when the analysis goes away, you are able to see very clearly the underlying brain is looking pretty normal. It's not that the gray matter is extremely thickened and over there or not, but this is what the VBM showed us. Then we went to the PET, and the PET, we are looking at the same area. If you're able to see, there is the same area is having a foci of hypermetabolism over there compared to the contralateral side. Until and unless we merge these images, we will not be able to identify if it's the same area. So after merging the images, we get something like this, and we have the PET data that is overlaid. I will just show you how. I don't have the slide for PASCOM on this. Let me see. Are you able to see my image now?
Yes, yes.
Yes. Okay. Okay. So this is PASCOM, what I was talking about, developed by Amrita Cochin, and this is the PET. So first I'll show you how it looks. Contrast inspector, and this is the normal PET scan that we get, and it's difficult for us to identify which area we are going to resect based on the PET scan. And then we have the PET scan that is merged with the MRI to give us a better idea. And then we have something called as the PASCOM, which gives us the highlights the area which are abnormal or having a hypometabolic pattern compared to the contralateral side. So this is the PASCOM, and of course it's going to show multiple areas of hypometabolism. But we were interested in this area because it was correlating with a very EEG. The area of hypometabolism here as well as anteriorly is nothing but the spread across the seizure. So post-ictally, the area where the electrical activity is spreading apart from the seizure onset zone will also look hypometabolic. So it requires some amount of training to understand which area it is. But with PASCOM, we are able to do a good job, and we are able to find out which area exactly we want to resect. I'll go back to my presentation, and okay, we have this as the PASCOM. And then we have the texture analysis, where we have the intensity of the gray white matter. So the intensity of gray matter is abnormal over here compared to the contralateral side. To the naked eye, it looks absolutely normal. And this is what we did. We mapped out the area. On the image on the left is the neuronavigation thing, where we have demarcated the area we want to resect, which looks absolutely normal. When we open the skull, we do our mapping. The image on the right is the subdural grid, where the epileptologist comes into the operation theater and tells us whether those areas on the surface are having any abnormal electrical discharges. Then we put a depth electrode inside to look at the deeper structures inside, looking for the abnormal areas. And then finally, with concurrence and with the neurologist continuously standing behind us and telling us, don't remove that, don't remove this, we do end up removing that much part of the brain. And this is our post-op scan, where we have, this is the post-op scan merged on the pre-op scan, where we are seeing the area of resection that we have planned based on the PET, based on the texture analysis, and based on the morphometric analysis. And this is the child at 3-month follow-up, still doing better. Now, of course, she can sit with support. She's able to stand with minimal support. She has come a long way from where she is. Her development milestones have started to improve. She is seizure-free so far. And on conclusion, based on the early experience, our center finds multimodal image post-processing of MRI as useful adjunct for improving the outcomes in epilepsy surgery. That's all.
Thank you, Dr. Tarang. Excellent talk and good correlation with the imaging, which was very, very enlightening and very comprehensive.
Okay.
I have my first question, and then I can open it up for the audience as well. So regarding the PASCOM, I just posted a question in the chat box for Dr. Josna that since they are doing these FDG brain studies, are they using their own different software? And PASCOM is something that is exclusively used by you in your own lab or in your own setting, or do you guys kind of exchange notes like with the reads what the NuPad gives you?
Is Dr. Jyotsna going to answer that, or basically I
No,
am the one using the PASCOM over here. The nuclear medicine team is not having the software for PASCOM right now. They do attend the epilepsy meets, and we do have an intense discussion. But PASCOM is something that is limited to my lab and not beyond that. The nuclear medicine is overworked here in India, in Apollo also. Probably the time and effort that is required for this post-processing may not be that worth it, probably, in a private practice.
Okay, thank you.
Yeah. So right now we don't have it. We trying, maybe in the future we might have it. So as Dr. Tarang said, we are working around it, I guess, now.
Sounds good. And I think Dr. Halkar and Dr. Takalkar will have more input. We have PET-MR for brain imaging here at Emory, and we are using it more and more for epilepsy imaging, and Dr. T and Dr. Halkar can add more. I don't want to take the entire time.
Yeah, I have a question in the chat,
Sure.
if you can read it.
Let me do that. I don't see your question, Dr. Halkar.
Maybe I didn't send it.
Oh, now I can see it. So Dr. Halkar said, thanks for a fantastic talk, a complex subject made very easy. What percentage of surgery you do is for cortical dysplasia versus mesial temporal sclerosis? And the second part of his question is, how often do patients get post-surgical sclerosis-induced seizures?
The most common surgery we're doing is for mesial temporal sclerosis. It is easy to identify. from a radiological perspective. They get a lot of referrals to the epilepsy team. And once there is a electro radiological clinical match, we go ahead with the resection. Probably 70% would be temporal lobe surgery. 30% is MRI negative dysplasias and stuff. We are not only dealing with dysplasias, we do a lot of stereo EEG. Sometimes this multimodal image processing leads to nothing, and we are stuck. Like multimodal image processing is showing us something else, and the localization from a clinical point of view is somewhere else, and the EEG is showing us somewhere else. It is sometimes a mess. We then end up putting electrodes in the brain and trying to get more definitive answer as to where it's starting from. Sometimes in spite of all that, everything fails and we just give up and we say that maybe you come back again after 6 months, and then we rediscuss the case again. uh, how often patients get post-surgical sclerosis induced seizures? So yes, there has been a lot of literature in post-surgical sclerosis induced seizures. It depends on the surgical technique. So where we have been trained in Milan, we don't use cautery for burning the brain. We simply scoop out the brain that is abnormal, and we let the hemostasis take place in the brain on its own naturally, or with some agents that we use to achieve hemostasis. Like whenever you use a bipolar cautery, you tend to burn more nerve cells in the surrounding area and cause further sclerosis, which may in turn cause seizures. My experience at Apollo has been limited. It's been only 3 years since we have been doing this at Apollo. And in my 3 years of experience, we haven't got back a patient with post-surgical sclerosis-induced seizures. But I'm sure as the time passes by, we will get a few cases and we will deal with it.
Just a quick piggyback to the same question. Is it related to the technique that leads to post-surgical sclerosis-induced seizures?
Yes, definitely is what we feel as surgeons, and all surgeons feel that their technique is better than the other surgeon's technique. But yes, I feel that when you're handling tissue, you have to be very careful inside the brain, because sometimes when you're handling tissue, you may cause more damage than otherwise. And the way you handle tissue determines how much of sclerosis is going to happen at the area where the healing is going to happen.
Thank you. Another question from Madhavi Tripathi. Excellent talk, Dr. Tarang. What is your experience for FCD type 1 specifically?
Any focal cortical dysplasia, the outcome is really good. FCD type 2B has the best seizure freedom outcome because they are clearly seen on the MRI and it's easy for us to find them out. Plus, the surgeon gets a very nice feel during the surgery. It's like more tough. But FCD type 1 has got lower seizure freedom rates compared to FCD type 2. But if with the multimodal imaging techniques that we are using, I think our detection rate is much higher and we are able to resect a good chunk, and we are getting seizure freedom rates, may not as good as FCD type 2, but still somewhere nearby.
Thank you.
Sam, I have a few questions. Dr. Tarang, excellent talk. And as I echo Dr. Halkar, that you made a complex topic sound very, very easy, and certainly great that you are processing it yourself. It's not easy for doctors to use MATLAB and SPM12 and all that. So hats off to you for doing all that. I'm just curious that you're comparing it to 100 cases. I'm assuming those are all your cases on your own equipment for the normal database, because
so
that's the most.
I think yes. So that is a very, very good question. So no, those are not my cases on my database. Those database is extrapolated from Germany for VBM. And for the PASCOM, there is no database. So PASCOM we feel is more reliable. Same for the texture analysis, it's extrapolated from. So there have been a lot of discussions on this database being scanner specific. what you've asked is a fantastic question, which I will say that yes, we don't have a very good answer to it. Unfortunately, for getting 100 patients to get an MRI done and to get the database from that and to generate a database from it, I require an engineer's help, and I require a lot of institutional help. This being a private practice, I do not possess it in my setting over here right now. So I am basically extrapolating it on data sets which have been used elsewhere. Uh, the predominant data set which is used for texture analysis is based in UK, and the data set which we are using for VBM is based on the data that we have got from Germany, and the PASCOM is data free because it's simply comparing the opposite hemisphere.
Yeah. So I mean, our next SNM India annual meeting is actually being held in collaboration with the local IIT actually. So there is a lot of crosstalk between medicine and engineering even in India. And I think you should be able to leverage the expertise of IIT engineers in India to develop your own thing. And
I wish that barrier is not existing there, but I feel that barrier is still there over here. Not only in engineers, it's like between specialities also, it's difficult
Yes.
to break the barrier.
Yeah.
We are a long way from a multidisciplinary approach, especially it's difficult for me to comment on it, but it's been difficult just to hold the epilepsy team together also here at Apollo. Involving the psychologist, involving the radiologist, involving the nuclear medicine specialist. So many aspects of it is difficult to cater to, but eventually I think everybody will come and help each other out, and it will work in our favor.
Yeah, we have a weekly multidisciplinary conference for epilepsy every Tuesday, so that brings all the team together, so that helps. My next question is a little more kind of a philosophical, not philosophical, but maybe pathophysiology. In focal cortical dysplasia, there is gray matter thickening. And on FDG PET, you're seeing on an interictal scan hypometabolism. And gray matter is the one that takes up FDG more. So logically, you would expect to see increased uptake because it's thickened gray matter there. So what's happening in the gray cells there that they are hypometabolic in spite of being thickened?
So when we're talking about focal cortical dysplasia, it's predominantly at the junction of the gray matter and the white matter, and not per se the gray matter completely. These are neuronal cells which are migrating from the subependymal zones and have not been able to reach the cortex, and they are stuck somewhere in between. So in the white matter also, you will see these cells scattered around. So in a normal white matter, you will see only white matter. But in cases of dysplasia, these abnormal neurons are stuck in the white matter because they never made it up to the cortex from the subependymal zone. So we have that gray-white matter zone, which is slightly blurred and not having that sharp contrast between gray and white. Then we have some thickening of the gray matter, yes, because the cells are slightly bigger in size. As I showed you in one of the slides earlier, the cells are dysmorphic and larger in size. Their uptake of the FDG is different from the uptake of FDG in the normal cells. These are large cells and balloon cells. These are dysmorphic cells. So we are looking at a junction, a thickness, and intensity. There are multiple factors that are playing over there. Between the seizures, there is a kind of a negative potential that happens, and it goes into a subtle area where there is no metabolism happening over there because it was hyperactive for a certain time. I'm not getting the right word for it, but it becomes hypometabolic. But during the PET, if the patient is having seizure, it will pick up as a hypermetabolic area because and that is why it is necessary for us to have EEG during the PET. So which has been a technical challenge for us. Currently, we are not doing EEG during the PET. So when we do EEG during the PET, we are able to say that if there is a seizure going on, then we know that we have to look for hypermetabolism. But if there is a seizure that has its interictal clearly, then we are looking for hypometabolism. Sometimes the seizures can be very subtle and cannot be made out without
Clinic.
any EEG.
Yeah.
Yes.
Yeah, I highly
May I
recommend.
ask? May I ask? Do you do EEG in
Yes.
at your
Yes.
center during the PET?
Yes, we
Yes.
do it. It's scheduled in a way that it's always scheduled with EEG tech to come in and monitor
Okay.
during the. So we do it during the uptake phase. When the patient is being scanned, we don't. But during that 1 hour of uptake phase, the patient gets EEG monitoring continuously.
EEG monitoring done.
Yeah.
Yes,
In my experience, we do EEG 30 minutes before injection, 30 minutes after injection of FDG.
Okay.
Cortical dysplasia MRI is certainly much better than FDG PET because that can be a very sliver of thin
Yes.
dysplasia. Our PET resolution is not so good, so we'll have partial volume or a finite resolution effect, and it will not look so. It will not appear hot at all. So MRI is a better way to look for cortical dysplasia. FDG PET is mostly for mesial sclerosis. That's where I have one quick question clinically for you in terms of Indian subcontinent.
Yes.
Here at Emory or even in general US, most of the mesial sclerosis for surgery comes after failure of medical treatment or drug-resistant epilepsy. So patient has already taken 10 to 15 years of anti-epileptics, and his formative years have been compromised in development because of the anti-epileptic treatment. So even after surgery, even though the patient becomes seizure-free, he or she may not be very good functionally. Functional capacity goes down. So
Yes,
my
sir.
question is, what is your average age of surgical treatment for mesial sclerosis? Is it much
So,
earlier, or
yes.
do you start doing surgery before the patient becomes medical treatment resistant? Because that may have much more impact on socioeconomic impact of the surgery.
Yes, sir. We have never operated beforehand in a patient who is being able to manage it with medication. We've had a discussion with few patients as to we are seeing the hippocampal cirrhosis, but the patient is doing well on medical management. Regarding the temporal lobectomy, we have been aggressive in the last couple of years trying to convince them, but it's not an easy job to convince patient to undergo surgery when they are doing well on medication. Uh, uh, yes, I completely agree with you. The percentage of my predominant practice is pediatrics. So I'm a pediatric neurosurgeon who is dwelled into epilepsy surgery. So I get much younger patients compared to an older population. Also, I guess the older population, I completely agree with you. In spite of surgery, the functional outcomes is not that satisfying. But fortunately, in my practice, since my bulk of practice is pediatric neurosurgery along with epilepsy, it is much more satisfactory. Like the case I showed you, I generally cater to patients with hemimegalencephaly at 3 months, 5 months. Uh, the my average age would be less than 10 years in most of the cases. Uh, the epileptologist with whom I'm associated, she herself gets a good chunk of pediatric epilepsy. So I think 60% of her practice is pediatric epilepsy, and 40% is adult epilepsy. I do adult epilepsy work also, like temporal lobectomies, but overall the numbers are less because the practice of my epileptologist and myself is predominantly pediatric. That is why our success rates are slightly different, and I feel children do much better with epilepsy surgery than adults. Much more satisfying results also.
Good, good to know.
Yes.
Thank you very much. If you don't have any more questions, thank you. I would Thank Dr. Tarang for his excellent talk and very comprehensive in explaining the different aspects, combining clinical and imaging. I wish everyone a good weekend, and we'll see you next time. Enjoy.
Just Dr. Tarang, excellent talk, and I'm
Thank
very
you. Thank you, Dr.
happy and proud to be working with you. Thank you.
Thank you. Thank you, ma'am. Thank you. Thank you for the opportunity. Thank you, everyone.